Hello, and welcome to our webinar. My name is Tracy Cook with Zacks Healthcare Communications. I'd like to welcome you to our webinar, Parenteral Nutrition in Preterm Infants, with our speaker, Allison Rohr. Ms. Rohr is currently a neonatal dietitian and nutrition management center manager at MUSC John Jenkins Children's Hospital in Charleston, South Carolina. He specializes in the development of nutritional plans for low birth infants, surgical neonates, and infants receiving ECMO support. Ms. Rohr has published several articles and research in peer-reviewed nutritional journals and has written a book chapter on nutrition and the principle of neonatology. Disclosures. Our speaker has no financial disclosures or conflicts of interest related to material in this presentation. This educational activity has been supported by Baxter. Continuing education for physicians. This activity is approved for 1 AMA CRA Category 1 credit. The accreditation statement is below. Continuing education for pharmacist. Following Accreditation Council for Pharmacy Education Standards, this activity is offered as a joint providership between the University of New Mexico College of Pharmacy and Zacks Healthcare Communications. The accreditation statement is below. Continuing education for dietitian and nurses, this activity has been approved for 1 contact hour for nurses and dietitians. The accreditation statement is below. And with that, I'd like to welcome our speaker, Allison.
Thank you so much. So, in 2023, the American Society for Parenteral and Enteral Nutrition, or ASPEN, published guidelines for parenteral nutrition in preterm infants. The purpose of this presentation is to review the evidence and recommendations provided, address misconceptions in the provision of omega-3 fatty acids for the prevention of cholestasis, identify areas of ambiguity, and future research needs. Here is the reference that we're going to be diving into today, and you can see the panel of authors or the task force of experts. So the study goal was to provide recommendations on pre-identified questions as they related to parenteral nutrition in non-surgical preterm infants less than 37 weeks. You can see from the hierarchy of evidence that the authors, who are a task force of experts, they aim to review high levels of evidence using systematic review methodology. The task force extracted randomized control trials, performed grade assessment of quality, and where applicable, so 3 or more comparable studies reported for an outcome, they were able to generate random effects summary statistics with fluorescent plots. Importantly, a bias panel composed of 3 researchers assessed bias in the included studies. In total, there were 2,460 citations reviewed, and 57 clinical trials addressed at least 1 clinical question with a pre-identified outcome. Areas of interest include the timing of parenteral nutrition initiation, parenteral amino acid doses, lipid emulsion, or ILE dosing, and composition, especially as it relates to parenteral nutrition associated liver disease, or PNL. Additionally, which components of PN can be related to growth as well as neurodevelopment. Some examples of primary outcomes are listed to the right, including growth measurements and biochemical results. These may or may not be the definitions that your institution uses, but these were the definitions defined in the study. So the grade process distinctly separates the quality of evidence from the strength of the recommendation statements. Evidence quality describes the ability of the available evidence to answer the research question. This is the PICO question, so population, intervention, control, and outcomes. The strength of the recommendation describes the clinical panel's assessment of potential harm versus benefit of the recommendation, and that is independent of the evidence quality. In the example within the text, we learn that a recommendation may be strong despite comparatively weak published evidence if the net benefits outweigh the harm of its adoption. Recommendations that were based mainly on expert opinion were considered weak. So we know that preterm delivery is a nutrition emergency, and how important parenteral nutrition is for providing early nutrition to minimize the disruption of nutrients from the placenta. The initial protein provided in PN prevents catabolism with the goal to promote anabolism and ultimately promote positive nitrogen balance, which also requires adequate non-protein calories. We also have lipids, which provide a source of essential fatty acids. Benefits include minimizing the nutrient and growth deficits, bypassing the immature gut, and acting as a supplement to the transition to full feeds. In fact, this guideline's target population of preterm infants is expected to advance to full enteral nutrition without difficulty, except for in the event of necrotizing enterocolitis or NEC. And it would be to act as a bridge to full enteral feeding. While necessary for short term, we know that parenteral nutrition is less than ideal for long term for the preterm baby. Complications include acute metabolic disturbances such as hypoglycemia, hyperglycemia, metabolic acidosis, hypophosphatemia, along with other electrolyte abnormalities, and hyperlipidemia. There's also acute mechanical complications such as infiltration or thrombosis. And we have chronic systemic complications such as metabolic bone disease and parenteral nutrition-associated liver disease, or PNL. There's also risk for bacterial or fungal infections, especially central line infections as a major cause of morbidity and mortality with prolonged use of intravenous catheters. The brain is the most metabolically demanding organ in the preterm infant, and it consumes the greatest amount of nutrient resources for its function and its growth. Suboptimal neurodevelopment outcomes continue to affect 20 to 45% of preterm babies and up to 50% of babies who are born extremely low birth weight. Weight gain, linear growth, and head circumference are all markers of nutritional status and are independently associated with long-term neurodevelopment. In contrast, poor growth or extrauterine growth restriction is associated with worse neurodevelopmental outcomes. This review of evidence highlights several questions related to neurodevelopment to remind us that the most important outcomes can't be concluded at NICU discharge. Follow-up for these developmental outcomes is crucial to developing early guidelines as they relate to nutrition. And one piece of text here is that nutrients do not function alone to stimulate brain development, but rather in concert with growth factors, which in turn are dependent on adequate nutrient status, for example, protein and zinc, as well as on physiological status. So, according to the Academy of Pediatrics, adequate nutrition for the preterm infant should provide nutrients to approximate the rate and composition of weight gain for a normal fetus of the same postmenstrual age. Serial measurements of weight, length, and head circumference would be obtained typically on a daily to weekly basis and compared to growth reference standards. Most common growth charts include the Fenton or the Olsen. However, modern day intrauterine growth charts also include the Intergrowth 21st, NICHD, and the World Health Organization, or WHO, though neither is agreed upon for use in fetal growth monitoring. We do know that extrauterine growth restriction is a universal problem. Many argue against comparing a preterm infant with different physiological, nutritional, and environmental postnatal conditions to a fetus that would be the same gestational age. It's a very complicated argument with a lack of standardization for what extrauterine growth restriction really entails. Are we misclassifying infants with growth failure and therefore promoting an aggressive nutrition approach that is then linked to disproportional growth, adiposity, and increased risk for metabolic syndrome? There are studies that indicate accretion of fat-free mass as opposed to adiposity is equally important for neurodevelopmental outcomes, and we cannot rely on measures of weight alone. While this is not used in clinical practice, we do have that PPOD here, where we can see the baby having its measurements for fat-free mass versus a fat mass. Now to get into the questions asked by the panel. This one has to do with the timing of parenteral nutrition initiation. In utero, the placenta provides necessary nutritional support to the fetus, but that continuous supply of nutrition is discontinued when the cord is cut. Thus, providing nutrition either by way of breastfeeding for that uncomplicated term baby after birth, or starting parenteral nutrition for that preterm infant is indicated within the first 30 minutes to 1 hour of life. This is often termed the golden hour. It's that crucial time in stabilization from respiratory management, temperature regulation, along with line placement and initiation of nutrition support. So for the very low birth weight infant, TPN is initiated shortly after access is obtained. The authors conclude from question 1 that the prompt initiation of parenteral nutrition, or PN, is recommended. In one study, infants experienced a significantly smaller postnatal weight loss as a percentage of birth weight with earlier initiation of amino acids and lipid emulsion, or ILE. However, the study was really small, with only 40 infants in each group. The days to regain birth weight were lower across all 3 studies identified, but were not statistically significant. Question 2 asks, in preterm infants, compared with lower doses of parenteral amino acids, do higher doses of parenteral amino acids improve growth outcomes? A total of 15 trials were able to be assessed in this question. The initial amino acid dose varied in the clinical trials reviewed, as did the maximum target dose. The maximum target dose in the lower amino acid group ranged from 2.5 to 3.5 grams per kilogram per day, and maximum doses in the higher amino acid group ranged from 3 to 4.5 grams per kilogram per day. Only one study specifically targeted an amino acid dose greater than 4 grams per kilogram per day, although what they found was that infants in another trial did receive amino acid doses greater than 4 grams per kilogram per day based on that study protocol. It's important to note that these doses greater than 4 grams per kilogram per day are not well studied and may not be without harm. No growth outcome was statistically improved with higher versus lower amino acids. This includes the mean difference in maximum percent weight loss, the mean difference in days to regain birth weight, and the mean difference in weight, length, or head circumference at 36 weeks corrected age or discharge in patients who had the higher versus lower amino acid dose. The authors recommend against an initial dose of greater than 3 grams per kilogram per day, given that a single trial did find an increased risk of sepsis in those infants who are prescribed amino acids of 3.5 grams per kilogram per day at initiation. With regard to the target doses, a minimum of 3 grams per kilogram per day is recommended, but not exceeding the maximum of 3.5 grams per kilogram per day. These next 3 slides show the combined analysis of the forest plot for the mean difference in weight, as you'll see here, length, and then head circumference standard deviation scores at 36 weeks or discharge. These were all similar between groups, arguing against the need for higher doses of amino acids. Here is weight. And notably, here on the length, a single trial, that first trial, detected worse length for age standard deviation scores with that higher amino acid. Question 3 asks whether higher doses of parenteral nutrition amino acids compared to lower doses improve neurodevelopmental outcomes. Based on available evidence, the authors recommend parenteral amino acid doses at that 3 grams per kilogram without increasing beyond 3.5 grams per kilogram. You'll see the same as the previous slide with regards to growth. I think this question might have the highest practice change across the field for what amino acid doses are used in parenteral nutrition solutions. In terms of rationale for this recommendation, there is limited evidence comparing a maximum of 3.5 grams per kilogram per day of amino acids versus 4 grams per kilogram per day to suggest any improvement in neurodevelopmental outcomes. Heterogeneity in instruments used, such as the Bailey scales, as well as their timing, prevented any type of combined analysis. One trial did show a relatively small group of infants that had amino acid doses associated with lower scores at one measurement time, around 18 months corrected age. The authors stress the need to ask ourselves whether exceeding 3.5 grams per kilogram per day is not without harm. The combined analysis was really only possible for the outcome of cerebral palsy. The risk difference in cerebral palsy did not reach statistical significance, but tended to favor lower amino acids. In the trials included in the combined analysis, the higher target dose was noted to be 3.6 grams per kilogram per day, 4 grams per kilogram per day, or an additional 1 gram per kilogram per day above a routine amino acid dose. So that strong recommendation that was cited in the previous slide for the dosing between 3 and 3.5 grams per kilogram per day is within the range tested in these quote lower amino acid studies, and it's a cautious recommendation until further research can be performed with higher doses. Question 4. In preterm infants, compared with lower ILE doses, do higher ILE doses improve growth outcomes? Starting with the quality of evidence, there were only 7 studies that addressed this question, but many included altered doses of parenteral amino acids and or dextrose in addition to the lipid dose, and thus significant heterogeneity prevented any type of combined analysis. Additionally, some studies compared higher versus lower starting lipid doses, but had the same maximum dose, or had the same starting dose, but either higher or lower maximum dose. That max dose of lipid was 3.8 to 4 grams per kilogram per day, which is really not typical in any clinical practice. The authors therefore recommend daily advancement of lipid emulsions to a dose of 3 grams per kilogram per day if using a sole soy oil lipid emulsion or a multi-component lipid emulsion. Strong consideration should really be given to that composition of lipid emulsion to ensure an adequate provision of essential fatty acids and to prevent any essential fatty acid deficiency. In general, one can meet essential fatty acid needs with smaller amounts of pure soy oil emulsions than mixed emulsions. Your clinical science liaison, dependent on your lipid manufacturer, would be able to help you with these calculations and minimum dosing recommendations that would prevent any essential fatty acid deficiency. I'll break here for a moment to show a comparison of some of the different available lipid emulsions. In the first column, you'll find a sole soy oil lipid emulsion with soybean oil contributing to 100% of the fatty acids. Now, the 2 lipid emulsions in the middle are considered your mixed oil emulsions. They have varying amounts of soy oil, olive oil, plus or minus fish oil, and medium chain triglycerides, or MCTs. So there are reference requirements established that would prevent essential fatty acid deficiency. These have been described as 2 to 4% of total energy that would come from linoleic acid, and 0.25 to 0.5% from alpha-linolenic acid. So note that there is similar dosing of linoleic acid and alpha-linolenic acid between our multi-component lipid emulsions here. Now, question 5. In preterm infants, compared with a lipid emulsion containing 100% soy oil as the sole oil source, would altering that lipid composition by reducing the proportion of soy oil improve growth outcomes? So we have here multi-component lipid emulsions compared to 100% soy oil lipid emulsions. That was the comparison for all studies. The studies chosen all advanced lipids to 3 grams per kilogram per day, which is important. Unfortunately, heterogeneity in these interventions and growth measurements prevented any type of combined analysis, and there was no specific lipid emulsion composition for enhanced growth that could be recommended. The rationale for this recommendation is that the method of reducing soy oil differed between studies. Some studies compared a multi-component lipid emulsion that included fish oil. Some studies compared a multi-component lipid emulsion with fish oil. Some included olive oil, and others included MCT without fish oil. Heterogeneity in the interventions and the growth measurement, again, prevented combining any type of combined analysis. I will point out that out of the 8 studies with published growth outcomes, only 1 study resulted in a growth measurement that reached significance. In the study by Costa et al., there was an improved change or less of a decline in Z-score from birth to 36 weeks for length and head circumference. This was observed in infants receiving a multi-component lipid emulsion with fish oil compared to 100% soy oil. In another isolated study, there was no difference in the days to regain birth weight when comparing 2 groups with multi-component lipid emulsion to soy oil. One of what you see here is that soy oil, olive oil mixed emulsion in group 1. Given that there was really no overwhelming evidence for any particular lipid emulsion, no specific one was recommended for the purpose of improving growth. Question 6. In preterm infants, compared with higher doses of parenteral macronutrients, amino acids, dextrose, or lipid emulsion, does a lower dose of macronutrients reduce the incidence of parenteral nutrition-associated liver disease, or PNL? There were 5 study interventions that were identified, again with significant heterogeneity. No studies isolated the effect of dextrose on parenteral nutrition-associated liver disease, or PNL. A combined analysis was able to be performed for 3 groups that compared varying doses of lipids. However, no significant difference in PNL was found with a higher lipid emulsion dose versus a lower lipid emulsion dose. Therefore, given the low quality of evidence, the authors do not recommend routine reduction in the dose of amino acids, dextrose, or lipid emulsion when providing parenteral nutrition to preterm infants for that purpose of preventing PNL. A specific dose of ILE can't be suggested for the purposes of reducing PNL either, especially in infants who are not expected to be exposed to parenteral nutrition for a long duration. Now, within the text, the authors describe an example of prolonged duration of parenteral nutrition with a mean of 21 days. So if you're thinking about your institution and how long preterm infants are on parenteral nutrition, if it's in line with this, those are the types of infants that we would think about as benefiting from some of these recommendations. Now, the next question looks at the composition of the lipid emulsions on PNL and is divided into 2 questions. We have A and B. Question A, question 7A, is posed from the perspective that reduced soy oil formulations, with or without fish oil, would prevent parenteral nutrition-associated liver disease. Therefore, the trials included in this analysis utilized a lipid emulsion, with or without fish oil, in reducing the soy oil. So there's no evidence of reduced PNL with any specific lipid emulsion, whether it contained 100% soy oil or that multi-component lipid emulsion with or without fish oil. And no specific lipid emulsion can be recommended for the purposes of preventing PNL. These are the studies in which soy oil lipid emulsion was compared to any multi-component lipid emulsion. However, I wanted to point out that these are the 2 studies in the multi-component lipids that did not contain fish oil. In the forest plot, there's no significant risk difference between groups regarding PNL when considering multi-component emulsions with or without fish oil compared to soy oil. Now, the second part of this question took the perspective that both a reduction of soy and the inclusion of fish oil could prevent penile. So therefore, question 7b involves a subset of studies that compares a multi-component lipid emulsion with fish oil to 100% soy oil lipid emulsion. The combined analysis for this question also found no significant difference in the incidence of penile between the groups in comparing soy oil lipid emulsion versus that multi-component lipid emulsion with fish oil, and cannot recommend any specific lipid emulsion for the purpose of preventing penile. As a reminder, these recommendations are for babies without surgical disease. Secondary outcomes for ILE composition were also assessed in combined analysis. These included mortality and other comorbidities such as necrotizing enterocolitis, sepsis, bronchopulmonary dysplasia, or BPD, for example. However, no significant difference was found for any of these secondary outcomes, with the exception of retinopathy of prematurity, or ROP. The outcome of ROP was not statistically significant in any individual trial, but in the combined analysis, there did reach statistical significance. No studies that compared sole oil lipid emulsion to a multi-component lipid emulsion without fish oil were included in the analysis. So all of the multi-component lipid emulsions did include fish oil. The analysis, though, did not define a mechanism by which a multi-component oil with fish oil would alter the ROP risk. So further study is definitely needed to identify a potential for an lipid emulsion containing fish oil to reduce retinopathy of prematurity. Question 8 asks, in preterm infants, does reducing the dose of ILE reduce levels of unbound bilirubin? Why is this important? So preterm infants have slower clearance of free fatty acids. Elevated free fatty acids may displace bilirubin from the albumin binding sites and increase free or unbound bilirubin concentration. So this would allow the unbound bilirubin to cross the blood-brain barrier by passive diffusion. Serious brain injury may result when this occurs. Unfortunately, there's no clear cause and effect relationship of increasing lipid emulsion intake on unbound bilirubin. This may, however, be inversely related to gestational age. Holding or reducing lipids in the presence of elevated total serum bilirubin is variable, and it's not evidence-based practice. However, it is probably appropriate to decrease that infusion with any hypertriglyceridemia, which would indicate that the infant has met its current endogenous capacity with the current dose. So no randomized clinical trial was included to address this question regarding the dose of a lipid emulsion to reduce levels of unbound bilirubin. In summary, the authors are unable to recommend any specific ILE dose for the purpose of reducing unbound bilirubin, but suggest the need for clinical trials that would test lipid emulsion doses that may reduce that encephalopathy risk. Question 9 asks, in preterm infants, does a reduced dose of lipid emulsion reduce the risk of sepsis? Only one study evaluated higher versus lower dose of the same lipid emulsion, but found no difference in sepsis. What is highlighted here is really the importance of meeting a preterm infant's energy requirements. Evidence is lacking to suggest benefit of a dose reduction of lipid emulsion, which would thereby reduce calorie intake and fail to meet a baby's energy needs. So with that, the authors recommend against a dose reduction of lipid emulsion to prevent sepsis. Question 10 asks whether providing specific parenteral micronutrients would improve growth outcomes and reduce the risk for morbidities in preterm babies. So the micronutrients that were included in some of these trials included acetate, carnitine, glutamine, manganese, and also iron, with or without the use of erythropoietin. Prematurity-associated morbidities included osteopenia prematurity, BPD, sepsis, and growth. There is insufficient information to identify specific doses of these nutrients that would alter prematurity-related outcomes. Unfortunately, no studies evaluated osteopenia prematurity as a specific outcome that would be associated with a specific micronutrient, mainly mineral, or with a specific dose. So with that, parenteral micronutrients should be provided in amounts that are advised by consensus guidelines. We have ASPEN or the European Society for Pediatric Gastroenterology, Hepatology, and Nutrition, or ESPGHAN, among others. Now, it's really a fair question to ask whether providing standardized parenteral nutrition solutions over customized parenteral nutrition solutions can be associated with growth outcomes. Parenteral nutrition is both costly and relatively time-consuming to prescribe. It requires multidisciplinary collaboration between physicians or advanced practice providers, dietitians, and pharmacists. So this high alert medication can have an array of errors in management. Given its complexity, there is potential to standardize these solutions, which seems advantageous. However, there is a notable absence of clinical trials to evaluate this question. And therefore, outside of the first 24 hours after birth, when that starter TPN or vanilla TPN is typically used, a standardized PN solution for routine care is not recommended. Despite the lack of data, there may be benefit for the low resource setting to utilize such standardized solutions. Additional study through clinical trials is warranted to determine if different PN solutions standardized for specific time periods would show improved safety and efficacy through adequate growth and development. Finally, we have only one randomized controlled trial that was included in review for use of insulin to improve growth outcomes. In this study, insulin was provided by continuous infusion outside of PN with titration as needed. The tight glycemic control group experienced greater incidence of hypoglycemia despite improved change in standard deviation score for head circumference. Given this and the absence of any long-term neurodevelopmental benefit to the use of insulin, insulin cannot be recommended for the purposes of improving growth outcomes for preterm infants. Multiple limitations and potential research directions are listed here. What are some areas of opportunity that should be considered important for future study? I wanted to point out that there is definitely need for standardized definitions and outcomes, especially like biochemical measurements, such as hypertriglyceridemia and essential fatty acids. In fact, even full feedings as poorly defined among researchers. Is it the time when PN is discontinued? Is it 140 versus 160 mLs per kilo per day? Based on birth weight, based on infant's current weight, it's all very variable. We also know that while parenteral nutrition usually stops in the first few weeks of life, enteral nutrition continues on through the course of the NICU stay. Nutrition prescriptions carry on after hospital discharge. So are there trajectories of illness and or growth during parenteral nutrition exposure that are modified by enteral nutrition? Additionally, anyone who takes care of this group of periviable infants, so those that are 22 to 23 weeks gestation, knows that those babies don't necessarily play by the rules. They have unique nutritional requirements that are vastly different from their more mature preterm infant counterparts. So specific PN dosing of nutrients for this group is warranted. Finally, thinking about some of the literature with regard to nutrition support in the critically ill child or the adolescent, we have to consider whether in the preterm infant, whether times of critical illness and IV infusion would potentially be harmful or associated with any adverse outcomes? Does this infusion of nutrients only add to the metabolic stress that these babies are already under? A set of evidence-based guidelines for the surgical infant who requires long-term PN is also warranted. I wanted to thank you very much for your time and attention to this very important topic to improve parenteral nutrition prescription for your patients. Thank you.
Thank you, Allison, for that wonderful presentation today. We'd also like to remind everyone today about the continuing education credits for physician, pharmacists, nurses, and dietitians. For physician and nurses, please go to www.saxtesting.com/RB, register at the site, and complete the evaluation and test to receive your certificate. For registered dietitians, please go to www.saxtesting.com/RB, register at the site, complete the evaluation and test, and you will receive your certificate via email. For pharmacists, please go to www.saxtesting.com/RBPharm, register at the site, and complete the evaluation and test. You will receive your certificate by email with complete instructions to report your CPE. We do have a couple of questions now for you, Allison. Our first question: has anything changed in your practice since the publications of these guidelines?
Yes, that's a great question. Since these guidelines have been published, we routinely stopped providing greater than 3.5 grams per kilogram per day of parenteral amino acids. And I say that routinely, so 3.5 grams per kilogram per day is pretty much our max. And we also did slightly modify our parenteral protein for babies who are less than 1,000 grams, but they're right around that 3 gram per kilogram mark for protein when we initiate PN as well.
Excellent, thank you. Allison, our next question: what were the surprising recommendations that you have found in the guidelines?
Yeah, so I think maybe I wasn't so surprised that there weren't any specific recommendations for lipid emulsions made, just considering that there are such a wide variety of them. But it was really surprising to me to see that there were these newer formulations of lipid emulsions are being used in preterm infants, and so they are well studied, and that there's no specific author recommendation, should have kind of that reassurance to centers who might be using one that they find that nobody else is using. But knowing that, there is no specific lipid emulsion that's going to benefit growth or neurodevelopmental outcome, and that using a multi-component lipid emulsion with fish oil is not always just the answer.
Excellent. Thank you, Allison. That's all the time we have for questions today. We'd like to thank everyone for attending today's session, and we wish you have a great rest of your day. This concludes the session.